I was in the School of Public Health. I'm being on 11th
It's a great pleasure.
I was directing the Healthy Kids Club.
Dr. Aaron Wiedelbo. So Aaron is currently an associate professor in the Department of Biostatistics and Epidemiology at the College of Public Health at the University of Oklahoma Health Sciences Center. So he has an MS in Public Health from the University of Utah. He has a PhD in epidemiology from the University of North Carolina at Chapel Hill, and he's also been an EIS officer for the station in New Mexico. So he's done a lot of work in infectious disease, pertussis as a PhD dissertation topics, lots of infectious disease work while an EIS officer in New Mexico, Oklahoma, and we're going to hear some of the work he's been doing there during his presentation. So welcome, everyone.
Well, thank you very much, Dr. Scallon. That was a very kind introduction. And it's a pleasure to be with you. As Dr. Scallon said, so the topic of my talk today is an epidemiologic investigation of necrotizing enterocolitis among premature infants. And it was a challenge for me to decide what to talk about because as I've met with many of you on a one-on-one basis, the majority of my funded time is actually not on necrotizing enterocolitis. But I have been the PI of this particular project. It had some funding initially on, but it didn't have enough funding to necessarily get me all the way through. So I've had to work on this particular project over a number of years, and it's finally to the point where I'm ready to publish and to use these data as preliminary data for, R01 or other type of grants. And I think that this is just kind of an interesting broad spectrum epidemiologic talk that hopefully will get a lot of us talking. But anyway, so before I would like to just supplement a little bit. Dr. Scallon gave a very nice introduction of my background, but I might fill in just a couple more details, and then I'll go into the standard scientific talk. So as Dr. Scallon noted, these are the places that I've been. But the detail that I wanted to fill in with the University of Utah is I got bitten by the bug of applied epidemiology there. So what happened was we have the Huntsman Cancer Institute as part of the University of Utah, and one of the physicians there happened to see an elderly man, and he was talking to the daughter saying, we've seen a lot of brain cancer cases from your county recently, and that just sparked the interest in this particular lady, and so she put an ad in the paper on her own dime and said, if you live in our county and you have brain cancer, come talk to me. And so, she's not an epidemiologist, doesn't know anything about it. She didn't know about metastatic cancer or origin or any of that stuff, so she gets this long list of cancer cases. And of course, that there's probably a culprit in the area, right? And so they're concerned about an incinerator in the county that they want to have shut down. And so they're all convinced that this incinerator is causing this increase in brain cancer. And so so the county gets overwhelmed. They talk to us. The faculty is like, oh my gosh, brain cancer cluster investigation, really? Let's give it to the students. And so so I was the one that got it, but for me it was awesome, right? Because it's a very applied experience. And the other thing that made this cancer cluster investigation kind of interesting for us is someone at the cancer registry made a mathematical error where we were calculating rates by zip code. And so in one particular zip code, they thought that only 3,300 people lived, but it was actually 33,000 people lived there. And so it doesn't take a lot to figure out that the incidence rate was 1.1, but the way he calculated it was 11. And so that only fueled the speculation that there really was an issue. So, obviously I'm not talking about this cancer cluster investigation. This went the way of almost all cancer cluster investigations that we didn't find anything. But I learned a lot about the methods, applying what I had learned in class, and really got to get that sense of working with county partners and whatnot. And so that really translated when I went to University of North Carolina as well. My dissertation was, had some very rigorous methodological training, and I really enjoyed it. But I also knew that I heard about EIS while I was there. I wanted to learn about what I should do to work for CDC. So right away, I also started working at the North Carolina Department of Health. I got to help write their state epidemiologic profile on HIV, AIDS, and STDs, and so got a lot of that applied training as well. And and then was fortunate enough to work for EIS in Santa Fe, New Mexico for a couple of years. And that leads me then to my overall career goal, which is I would really like to bridge academic and applied public health. I'm not the type of faculty person that when I work with my students, I say, you could work at the health department, but if you're going to be cool like me and, stick my nose up a little bit, then you're going to have to be, this rigorous academic like me. And that's, maybe good, maybe bad. I just wanted to let you know that where I am, so you guys make an informed decision. But this is where my passion really lies. And so I try to really use infectious methodology, particularly disease surveillance. And I feel like I've been able to use surveillance in a number of my funded work. As I said, so one of the big things that's funded right now, I've been working with the Dean of the College of Public Health. He's an expert on venous thromboembolism, a non-infectious topic. But we were able to apply my training in surveillance, and we've had a great collaboration to apply the methods to a non-infectious topic. And that work is going on, now 6 years at least. And but I decided not to talk about VTE because you'd be like, why is an infectious disease doctor talking about VTE? So, and then another one that I spend a lot of time with is the VA. It's a national center, and we do syndromic surveillance. So we're really thinking about ways that we can improve the positive predictive value. Because as you know, when you have syndromic surveillance, you just have this vast number of records, which even with high specificity, the positive predictive value really suffers. So we're thinking about using natural language processing to search free text, chief complaint, that type of thing that might really improve that positive predictive value. And related to disease surveillance is emerging infections. As many of you know, the bugs, they don't care. They don't know that they're an emerging infection or a bioterror agent or whatever. It just gets a lot of headlines in the newspaper. But for epidemiologists, we just use the same methods of surveillance and detection. And so, but I've had a chance to be on our university's emergency task force when PAM flu hit in 2009 and then Ebola in 2014 and now Zika. There's always questions at the campus level. What are we going to do to if students come from that area? Do we need to do any special monitoring? Do we need to do any special testing or follow-up? And then, with my goal of bridging academic and applied public health, I'm always meeting with the state health department, the county health department, whether it's developing training exercises, tabletop exercises, monitoring plans. And so I was like with Zika, they asked me to testify before the Oklahoma State Legislature on what was going on so that they felt they were informed on where to use resources. And then the final interest that I spend some amount of time on, and this is nice because it overlaps with a lot of student interests, is hospital-acquired infections. I sit on our university's infection control committee, and even though I direct a lot of our MPH students to the health department, but some of them get to work on at the hospital level as well, and work on Clostridium difficile. That's a particular interest of mine. So, just a few more words is. A few years ago, I was instrumental in writing our center's grants for the first one was CDC funded. It was a Preparedness and Emergency Response Learning Center. And then because the work was very similar to what HRSA wanted with their public health training center, I got to be a part of both of those teams and write large sections of those grants and really think about how we can use the training of the public health workforce that meets the goals of again, applied epidemiology, but then how can we also use the university resources and students and create those win-win situations? All right, so I actually will pause just a moment if you have any questions about my background or anything that needs clarification. Well then, without further ado, I will go on to the actual topic, epidemiologic investigation of necrotizing enterocolitis among premature infants. So first of all, we're going to go way back in time. You're like, what? He's been doing this for, this old? I don't know. But so 2007, I'm in Santa Fe, EIS. I'm on call. You never know what happens when you answer that phone, right? And an infectious disease doctor who works in with the NICU is reporting a cluster of necrotizing enterocolitis. And my first question is, what is NEC, right? So it ended up in an investigation of a cluster of 11 cases. It was a case series, total hypothesis generating study, but we were still able to publish it and work with CDC, and really got me going so that when I went to the University of Oklahoma, I was able to start this case control study. And but first, to answer the question of what is NEC, so it's referring to death of the tissue in the intestine. It nearly always develops in an infant, particularly premature infants. You do have some in term and some in elderly adults that are immunocompromised, but the vast majority of interest is in premature infants. The exact cause is unknown, hence why it's really great for an infectious disease epidemiologist to get to that etiology question. Oftentimes, as an ID doc, we know the bug, right? And so it's more a matter of risk factors. But this one's a little bit different. Some risk factors, we know that there's some hypotension. If you just thinking about the needs of our bodies, the most important organ in our body is our brain, right? And so whether we're a premature infant or whether we're an adult, the body is naturally going to, if we ever lack oxygen, it's going to try and feed the brain first. So what that means is if the premature infant isn't getting enough oxygen, the gastrointestinal tract is kind of low on its priority list. And so if it doesn't have enough oxygen, that tissue is going to start dying. And what can cause that? So it can be a lack of oxygen, it could be infection with bacteria, it could be both. And so, very, very challenging situation. You can see the list of symptoms there. I'm not going to read them out, but I have a table that's going to reiterate some of those anyways. In fact, here's the table. So staging necrotizing enterocolitis, there's 1, 2, and 3, suspected, definite, and severe. This is not the full criteria because the full table would just, this is already busy enough and I don't need to belabor it, but you can see that there's systemic signs, intestinal signs, and radiologic signs. And so as you go down from suspected, definite, and severe, you're adding on, like you always have that baseline, and then the baseline plus the next level, plus the next level. And so the most severe, I'm not sure, it's coming up here, with the radiologic signs severe, if you have pneumoperitoneum, which is basically that colon is bursting, is making a hole and everything's leaking out, then that's very severe, probably going to kill a premature infant. So definitely in need of surgery. But so there's this range. You can see that these type of things: temperature instability, apnea, elevated pre-gavage residuals means the baby's spitting up their food, and so a lot of things can cause, this is non-specific symptoms. So as a neonatologist, dealing with NEC is kind of tricky. They're trying to figure out a lot of things on their differential. But it is the most common and severe gastrointestinal emergency in preterm infants. It occurs in 7 to 12% of infants that weigh 1,500 grams or less. And so as we're going to get into the DAG, the model here in a little bit, just keep in mind that this low birth weight, which is correlated with gestational age, we need to choose one of them, and that's a known risk factor. So now we just need to figure out the next steps. And the mortality rate is high. I kind of already hit some of that information. So now let's go into the etiology. When you look at the textbook, the medical textbook, they're going to talk about, some are going to talk about 2 etiologic pathways, some are going to talk about 3 etiologic pathways. So even at the very baseline level, there's not agreement on the textbook definition. The commonalities are the ischemic and the infectious pathways. I kind of already mentioned that ischemic means this lack of oxygen, and then infection can be the presence of these bacteria that are not normal flora, right, that are going to cause tissue death. But then the third one that people don't agree on is enteral feeding. Because it's known that formula-fed infants have a much greater risk of NEC. And so as you see here, the odds ratio 6 to 20, those are point estimates, so the 95% confidence intervals are a little bit wider. So this is a known risk factor, and then just this aggressive enteral feeds being an elevated risk factor, they say, well, so if this feeding is a problem, then maybe it's its own etiologic pathway. And I thought, well, as I started doing the literature search, I wanted to think about it more as an epidemiologist and less as a clinician. You know, this field has really been driven by clinicians. And so as I really tried to get a grasp of it, I identified over 20 potential risk factors, but no study had done a comprehensive job, right? Study A looks at these 5, study B looks at these 5, and then some of them are contradictory. For example, some say glucocorticosteroids are preventive, and some say that they're causal, and so this is all over the map. And then just we identify clustering, and whenever you see a cluster of cases, then you start to hypothesize, is this infectious, right? And but then what about the sporadic cases? Do those mean anything? So I felt like this was only worthy of investigation if we could actually intervene. If it's just going to be premature infants and they're just going to be at risk, then there may not be any need of study. But if there's a way that we can clinically change the management and prevent the disease, then that's worth investigating. And this is where kind of my short list was getting to with the medication is antibiotics could either be a preventive or a risk factor. Same thing with glucocorticosteroids. And then finally, pain control. Mostly, I think that that's a risk factor, but just to kind of put that human element in, if you could, I don't know if any of you have had a premature infant. Thankfully, I haven't, but I, spent some time in the NICU to the point where I just, you love those babies and you feel bad for them. And if it was my baby in there and they're suffering, I would definitely be asking that neonatologist, like, can't you give them something for the pain, right? But as many of us know, even as adults, morphine and some of these very strong painkillers, they slow down the digestive tract, right? And they cause constipation and whatnot. So what's that doing in a premature infant who already has ischemia? You're in a situation where you want to give that premature infant as many calories as you can. You want to feed them because you know that they have to grow and get stronger and develop that immune system and gastrointestinal tract, and yet they're in pain. And so you're like, okay, let's feed them. Let's give them these painkillers. And then before you know it, you're giving them a life-threatening condition, necrotizing enterocolitis. So this is why I think there is still room to potentially change the clinical control. So the specific aims for my study was to determine if risk factors vary by etiologic pathway. I wanted, like I said, this very epidemiologic approach. Are ischemic cases different from infectious cases? Nobody had ever looked at that before. Everyone just said, well, this is NEC, so this is NEC. The next part was, can I use an epidemiologic framework to systematically and comprehensively assist risk factors? So like I said, I identified them all. Can I lay them out? And the best way to do that was to use a directed acyclic graph. Just by a show of hands, who's familiar with the DAG? Most of you are familiar. Good. Just didn't know how much background to go into this. So I developed a case control study at an urban hospital in a NICU. I'm sure you could guess which one it was. The sample included infants born between 2001 and 2011. We didn't continue collecting because at that point we switched EMRs and then it became very difficult to translate. But anyways, this was still a long period to get to try and get a large enough sample size. Still not as large as I'd like, but we restricted to preterm infants, so 36 weeks or less. We only included stage 2 or stage 3 cases, so we excluded all stage 1 suspect cases from either the case or the control. And we used the modified Bell's criteria, the full thing, but we collected the information on these symptoms as well, so we could confirm the diagnosis and not just rely on the neonatologist's diagnosis. We matched 3 controls for every case. and the factors were plus or minus 1 week gestational age, again, trying to control for that prematurity as a known risk factor. And then we matched on quarter of birth. So, for example, January to March 2005. And the reason why we did that is, as we knew, as you saw, this was from 2001 to 2011. Clinical practice might change. There's a few, and also knowing that clustering might be an issue. We just wanted to make sure that the cases and controls were coming from essentially the same time period. And then we also matched on index date or exposure period. And my next slide is going to go into that. So if it's not really clear what that means, hold on for a second. There were 13 cases that we were able to include that matched to either 2 or 1 controls. We couldn't find 3 for them, but we did have to exclude 6 cases because we just couldn't find a match control. All of these cases were 24 weeks or less, and as you can imagine, babies that are that young, they just don't live very long, and so it's very difficult to find controls that have an exposure period long enough to match to them. Okay, so here's this establishing the at-risk period for control. And this was one of those things that kind of going, when I read the literature, obviously mine isn't the first case control study to be done, but when I read the literature, I never really thought about, well, what do those controls look like as far as assessing the at-risk period? And it wasn't until I started doing the study that I'm like, oh, I don't know how long to collect data on these controls for. So I went back to the literature to see what I could find, and there was nothing. And I'm like, oh my gosh, there's a lot of just kind of new stuff that I got to do. So I don't mean to say that this is the best way, but this is starting a dialogue of taking a very systematic approach, and maybe maybe this can be improved in the future. But so I started off with the onset of symptoms in the case, and then I subtracted the number of days from which they were admitted, because usually, these premature infants, it's not like they go home and then get admitted to the NICU. This is basically their day of birth as well. So if their onset of NEC was, say, 10 days, then I used that 10 days. So when I went to the match control, I took the control's admission date and then started 10 days later, and so that classified as the index date of the exposure period in the match control. And then I just collected data for 5 days, so I would calculate a resolution date in the case and then in the control, so that I was collecting data essentially for some of the symptoms, or some of the risk factors. It depended. Some were 2 days before symptom onset, some days were 5 days before symptom onset, and then through the resolution date. But and I can get you my data collection forms if anyone's interested in that level of detail. But again, we just tried to be very systematic about defining what those windows were. Data were collected through the electronic medical record. We collected demographics, signs of infection, and then the hypothesized risk factors, both at the infant level and the maternal level. So here is my directed acyclic graph. And I'm not going to go over every box. It's a little busy, but I am going to walk through just a few key features of it. I would like to start here with prematurity and low birth weight, and then kind of direct your attention that we're going down to necrotizing enterocolitis. So we know this is a strong risk factor, and I wanted to find the ancestor variables first. So we identified maternal drug use and premature rupture of membranes as factors that may cause prematurity or low birth weight. Then the next thing that you might notice is that I have different colored arrows, and the blue arrows represent what I think to be the infectious pathway. The red arrows represent what I think to be the ischemic pathway. And the black was one I really couldn't decide. I thought that there was ischemic and infectious, a shared pathway. And so I bolded a few of these just because, like I said, I was hypothesizing that glucocorticoids might be a primary exposure that I wanted to definitely look at. And then enteral feeding products was something that I thought was really important. And as we get here to enteral feeding, you can see why I don't think it's its own pathway. From the infectious, I figure that it would be environmental transmission. So if that formula gets infected or contaminated with something, whether it's Bacillus cereus or an anaerobic spore former like Clostridium, or whether it's even Salmonella, like there have been outbreak reports of formula getting contaminated with Salmonella. So if those feeding products get contaminated, then that would essentially be an infectious mechanism. Whereas if we were just talking about those aggressive feeds where we overwhelm the digestive system, it can't digest it, then it would fall into this ischemic pathway. And so that's why it's shared. And then what else? I think those are the main things that I wanted to highlight about the DAG. But it was, and some of them, just to make it not too busy, I lumped a bunch of hypoxic and related events in one box, but in the model I could potentially look at them differently. So I still, at the data level, they're split out. So any questions or needing of clarification? Yes, please, Tessa.
This is just my lack of knowledge about care for premature infants, but the enteral feeding would be with formula or pumped milk?
Right. So the preference is if the mom can express breast milk, then you give them the express breast milk, and oftentimes you also want to add human milk fortifier to that express breast milk, which is going to increase the calorie content. And that's actually where I want to go ultimately with my hypotheses about the similarities between formula and human milk fortifier, because they're made by the same Enfamil and Similac and have potentially some of the same risk factors for contamination. But that's later on down the road. That's not really in this presentation. But yeah, was there more that I could help?
Is there any other way to feed a severely premature infant?
Yeah, so as soon as clinician suspects that baby and neonate has NEC or developing it, that they're going to take them off enteral feeds at all. They're just going to feed them through an IV.
Isn't breast milk also protective against NEC in some circumstances? Or
I think that you could. I guess yes. It just depends on how you conceptualize the disease model. If you say that breast milk is the standard and then formula is a risk factor, then you might not consider it protective. But if you were thinking like between the choice, if I'm going to be giving them formula and can I give them breast milk, then it would be protective. So It's kind of both sides of the same coin. Questions? So then I needed a case definition. As I said, this was the first time that anyone had really tried to parse out the outcome into two different groups. And so needless to say, there was no standard definition. So the way I approached it was, by default, I classified all of them as ischemic cases unless I could come up with evidence of infection. And my evidence of infection was that they needed to have a positive culture from one of these sites: blood, stool, urine, or tracheal. And again, these would have to, I'd get a clinician to look at these. It wasn't just they would have to be disease-causing type of organisms. But then also, if there was evidence of clustering, so 3 or more cases within 21 days of each other, I also considered evidence of infection. My statistical analyses, I use Mental Hensel for exploring categorical data just at a crude level. And then I use conditional logistic regression, given it's a matched study design, calculating or estimating odds ratios and 95% confidence intervals for NEC while controlling for the potential risk factors that was guided by the DAG, and then OR specific by the etiologic pathway. I used a kind of a combination, mostly a backward model to assess confounding and interaction. When I say backward, it wasn't the whole kit and caboodle from the DAG, but it was my hypothesized risk factors being informed by both the DAG and the crude analyses of those that were most significant, putting them in and then taking them out, but kind of multi-stage backward model. And then I use SAS. All right, so on to some results. We ended up including 86 cases, 47 of which were ischemic and 39 of which were infectious, and then 242 matched controls. The mean age was 29 weeks, ranging from 23 to 36.8 weeks. And I didn't show the difference by cases and controls since these were matching criteria. There was no significant difference. Here are some of the demographic characteristics: sex, race, ethnicity, and birth weight. and I wouldn't expect any of them to be significantly different, but I do want to draw your attention to two results here of race and ethnicity. Given that this odds ratio is actually statistically significant, then as I was going into the adjusted model, I was really going to look to see if black race was playing a role in further models. And Hispanic, I wasn't as convinced because it's not significant, but I just wanted to give you a kind of a preview that when we get to the results later, it's actually Hispanic that pops out and black doesn't. So, so somewhat interesting.
I'm sorry,
yeah, please.
How does that racial distribution compare to the general number of kids born in that hospital and the proportion of prematurity demographics?
That's an excellent question, and I have looked at the demographics by hospital, but I don't remember off the top of my head, so I'm going to punt that one, but I am familiar enough with just the overall demographics of the state from my other work. We have about, well, in Oklahoma County, we have about 70% white, and then Hispanic is about 13 to 15%, and black is about, I believe, 11%. So regardless, there is a larger representation of black and Hispanic, but also this is a large NICU, and you would expect it to serve some of the underserved populations racially, and other was just grouped Native Americans, Asian, and Islanders. Any other
repeat
questions?
your matching variables?
Sorry?
You repeat your matching variables.
Yeah, it was gestational age, the quarter of birth, and then this index, that exposure of that index time of exposure, that at-risk window. So I didn't match on sex, race, or birth weight, but again, birth weight is going to be highly correlated with gestational age, and I just wanted to put this up, which I think shows that given that these aren't significantly different, you can still see that even though we were controlling for gestational age, our cases do tend to be a little bit more on the lower birth weight, though. So, which is consistent. You would expect our cases to be sicker than the controls. But I will just say that when you're dealing with controls, like I avoid the term healthy controls because there's no healthy control in a NICU in these premature infants, right? So otherwise, they're not in the NICU. Okay, so other questions? All right, as I mentioned, the primary exposure that I really wanted to tease out is, as far as enteral feeding, because I want to move in this direction in the future, was enteral feeding. And we could measure it in at least 3 different ways. The total amount given to them, the total number of times they were fed, or the total days they were on enteral feed. And going into it, asking the neonatologists and the dietitians, they didn't really have a lot of insights as to which would be the best measure. So we just collected it all and then thought we'd look at it in our analysis. You can see that in crude analyses, they all had the same kind of tendency to be over, but we decided that total feeds given was going to give us the most power. And it wasn't just based on the p-value, but as we kind of moved forward, we felt like it was the right amount of observations where we could get a little bit better feel for the data. But I did try to, sometimes I put in other measures just so you could compare as it affects the interpretation of the data. Here, the crude analyses for the medications that I had highlighted earlier. Morphine just wasn't used, even though it's statistically significant, it's such a small number of cases that I decided not to pursue it in further analyses. But fentanyl really jumps out. Indomethacin, which my neonatologist actually thought was going to be the big one, doesn't seem to be significantly associated, and I did continue to just pop it in some of the adjusted models just to look, and it never panned out to much. Ibuprofen, not much, and the glucocorticosteroids, I never got to be statistically significant, but it does end up, I think, I remember, but it tends to be a risk factor as far as like I said in previous studies, it was on the greater than one side of the null rather than the less than one side of the null. But I certainly don't feel like I'm putting that argument to rest with my study. But as far as the meta-analysis approach, that's where that'll fall out. The clinical features, increased requirements for oxygen, birth asphyxia, and arterial and venous umbilical catheters. You can see that in the crude analysis, birth asphyxia is significant. Then Apgar scores, I have both 1 minute and 5 minute. There really was no difference between cases and controls. Just a few other features, exchange transfusions being small for gestational age. So basically there's no, this is a clinical judgment, but already we know these infants are small, but even for gestational age, if the clinician feels like they're really small for that gestational age, then they'll call them SGAs. And so we thought that we'd like to include that. Chorioamnionitis, this was, just as an aside, one of my MS students was really interested in chorioamnionitis and was able to do a thesis off of using these data and looking in full depth at chorioamnionitis. And so that work will come out soon as well. And then, not surprisingly, our cases were much more likely to die than our controls. Then on to the maternal factors, we have illicit drug use, gestational diabetes, preeclampsia, and premature rupture of membranes. And none of them were significantly associated, but just these were the ones that we thought were those ancestor variables in the DAG, and so we wanted to, they were still in my mind as wanting to include in the adjusted analyses just being ancestor variables. And not so much on gestational diabetes, mostly because that's something that we can't really control from a preventive standpoint. And then the other thing is, as moms that have gestational diabetes, they give birth to heavy kids, and so that's why it's more likely to be a preventive factor, but there just isn't enough to do much with it anyway. All right, and now, forgive me, this is just really a busy slide, but I will give you some time to digest it, and I'll try to walk you through. This is only among cases. We stratified it by etiologic pathway. So the orange bars are our infectious cases, and the green bars are ischemic cases. And this was, again, kind of hypothesis generating just to look and see if the distribution of these risk factors differed by the type of case they were. And, like I said, I know it's busy, but so fentanyl use, you can see that the infectious cases just tended to get it more often than the ischemic cases. And then here with the preeclampsia, we saw that the ischemic cases the moms tended to have more likely to have had preeclampsia than the infectious cases. And again, this was kind of just helping guide us in our model building. So now on to our adjusted results. This is my final parsimonious model for including all cases together. And we ended up with, like I said, I used the number of times fed, exchange transfusions, fentanyl, and having died. And so the interpretation of this 1.1 would mean that essentially for every increased time a premature infant is given an enteral feed, that they have a 10% odds of being a case. If we decided to use the number of days fed instead, the odds ratio is 2. So, basically the odds double for every additional time that they're on enteral feeds. And again, it's just, but not quite as powered. Yeah, Molly.
So is that clinically significant? Like, is that something that the doctors think is enough to...
Well, I think so. We're at the point where we're writing this up, but still trying, but it's not all the way teased out yet. So we're in these negotiations with the dietitians and trying to figure out exactly what that means. Yeah, but there is a bit of literature from dietitians trying to balance this out. Yeah. Other questions? Now I'm going to stratify it by the etiologic pathway. So we have our infectious cases here are ischemic, well, not just cases, but the cases and matched controls. And here we're just using the 3 different measurements again. Just I wanted to make sure that the choice of enteral feed wasn't telling me a different story. And you could see that the difference isn't that much. Maybe it's an issue of power, but I don't think so. So enteral feeding may not make a big difference as to whether you're an ischemic case or an infectious case. I really thought that the odds would actually be higher for the ischemic cases just because of that aggressive feeding. So even if there is a difference, I wanted this one to be higher, and it wasn't. Now this is the adjusted model, keeping with the number of times fed, including exchange transfusions, fentanyl, and fentanyl use, and having died. And this is where the real interesting results came in. Again, the infectious pathway here, the ischemic pathway here. So you can see a very big difference that exchange transfusions tend to play a much larger role among the ischemic pathway, whereas fentanyl use does seem to play a larger role in the infectious pathway. And I didn't include all the results here, but I did just additional looking. And if I among the infectious cases, if I pulled out the exchange transfusions, this OR didn't change a lot. It just became more precise. But I tried to put in some of those earlier risk factors like birth asphyxia and some that were statistically significant, and in these controlled models, they weren't even close. Like it was very interesting. It was a fun analysis to do. As I mentioned earlier, I was going to look at race and ethnicity, coming back into it. And so in the overall model, there wasn't much going on, but when I looked at the stratifying by infectious cases and ischemic cases, looking at Hispanic ethnicity, I realized neither of these are statistically significant, but the fact that they're on such different extremes of one still is hypothesis generating, and it's interesting to me that Hispanic cases may be more likely to have an infectious origin. I don't know if I don't know if this is real or if this is something to pursue, but really excited to report to it. Again, nothing really popped out with Black or other race. All right, on to discussion. How am I doing? I'll try to get through this quickly so you have time for questions. I don't have too many more slides. So, in summary, we felt that enteral feedings is associated with that case status, but not necessarily by etiologic pathway. It didn't really matter which measurement we used for enteral feedings. They provided consistent results. Maybe the interpretation of the odds ratio is all. Exchange transfusions and receiving fentanyl is associated with case status, and this is something that can be probably altered in clinical status. And again, NEC cases have a much higher odds of dying. The role of the etiologic pathway, so exchange transfusions have a stronger association among the ischemic NEC cases, whereas fentanyl use has a stronger association among the infectious NEC cases. I felt the DAG was quite useful. It helped me build a conceptual framework. It helped inform the hypothesis of the mechanism. It helped identify some of the factors and how I wanted to build them in the model. It informed the analytic plan, identify those ancestor variables. And then the next steps have you guys heard of DAGity before? Anyone use it? Some nods. So I haven't used it yet, but that's my plans. One of my mentors, like my methods teacher, Charlie Poole, back at UNC, he gave a SER live talk recently on DAGity, and I tuned in, and I'm like, oh, okay, I got to use DAGity to see if anything else comes out in this. And, my limitations, one of them is that my data source was electronic medical records. I'm sure many of you have used electronic medical records, and they're just lousy for research, but sometimes we use it anyway. This one was particularly lousy just because of the extensive number of text fields, and so these clinicians can kind of pick and choose which text field they want to put in their notes about these infants, and so kind of bleeding into my next limitation of using multiple data collectors over time. There might be heterogeneity in the data collection of trying to really train these data collectors to look carefully at all these different fields. But we did take a lot of time with some of my students' roles was to go back and check everybody else's work, and so I'm finally got to the point that I felt that the data were clean and trustworthy. And then another limitation is just there's no standardized risk period to conduct these case control infants, but hopefully, we're making progress on that front as well. So my conclusions are that the etiologic pathway is important in conducting analyses of NEC. Epidemiologic methods make a meaningful contribution to the field. A risk-benefit of fentanyl and exchange transfusions needs to be assessed at a clinical level, and also the amount of feeding given to premature infants still needs to be further assessed to help these infants. Thank you very much for inviting me here and letting me share my research with you, and I'd be happy to take any questions.
I'm just curious about kind of how this came about. So you obviously had this interest in NEC from your experience in New Mexico, but in this current climate, using electronic medical records as they are seems kind of more and more inviting. So can you describe did you approach the clinicians and how did that work and where was funding acquired?
Yeah, so my first source of funding was NIH, but I used the LRP mechanism. It stands for loan repayment, and it was very helpful because I was successful in getting it, and it gave me protected time, but it didn't give me funds to actually hire GRAs, and so that it was. So that was the funding, and that was for 2 years. And then as far as collaborating with the neonatologists, they were all over it. I mean, NEC is just one of the banes of their existence, so any help that they can get on this. And the one I work with, Andrea Leitner, she's actually come to my office a couple times saying, is now the right time for me to get an MPH? She really wants to get some more training and some skills in research. So I've had a really good working relationship with her. And so getting access to the medical record really went very smoothly. The IT person in their department just is like a wonder to work with. And when she left for the VA 2 years ago, I cried, and so, but why the motivation? There's multiple reasons. It's like you said, I got into it as a epidemiologist, but it kind of ties back to why I jumped ship from CDC and came to academia, is because it wasn't just this one, but it seemed like all of my investigations, you put out the fire, I would try to write it up, get it published and whatnot, but there was never that next step to really learn from it, right? And so I thought that that's the benefit of being in academia. You can write these grants, you can take the time, you have students, and you can really put in an epidemiologic framework. And why I thought this was great is when I reached out to, I don't know if, for those of you that are interested in hospital-acquired infections, so Cliff McDonald is like Mr. C. difficile himself. So, and he's there at CDC, and so the fact that he was going to give me not only the time of day, but gave me some mentoring on this project I just thought was a great blessing. And so, working with him, he got excited about this, and he's like, and this will speak. I don't want to take, I want to leave room for other questions, so forgive me if I'm going on too much. But no. But in a way, this is really interesting. Is that so we in our initial outbreak investigation, we tested the human milk fortifier because this was a cluster, right? So we're looking for an infectious cause. We're testing the human milk fortifier, and then there was some story among the nurses that they had an open jar of multi-use formula, which is just like a complete no-no in a NICU. And so then nobody was going to talk about it, and but we did get a hold of this the multi-use formula, and that didn't turn out to be hypothesis generating. But when we tested the human milk fortifier, it had this big distribution of contamination with Bacillus cereus. And the thing is that the standards for how much contamination is allowable in there is based on healthy term infants. And so I was really interested, if these are premature immune system, premature GI tracts, and the human milk fortifier is being made with the formula, could the human milk fortifier at a very small dose, is it still causing some type of a risk factor? And I know that I knew going into this case control study that it wasn't going to be powered to answer that question, which is actually the one that I really wanted to do. But like I said, I felt like there's so much preliminary stuff that I had to do that I needed to do this to give me credibility to go forward. So, I mean, there's more, but that's probably enough. Other questions? Please.
Thank you for your presentation. I had a question about your model. I mean, because I think it's a very interesting approach to trying to figure out risk factors and things like that. But can you tell me a little bit about why you put the variable died in the model, since you're looking at etiologic risk factors for the disease, and of course died happens afterwards, and what does that do to your model?
Yeah, I tried to include it with and without, and that's the very fun thing about biostatistics is most of the time the general rule of thumb is if you put a factor in, you're going to lose power, but every once in a while you have those factors that when you put it in, you actually get higher precision just because it's fitting your model better, and that's what happened with including having died in the model. It was controlling for that severity of disease, and the confidence intervals actually got tighter rather than wider. So it was a better model fit.
NICU and so many of them died.
Right.
So it's not really that they died, it's a marker of severity.
I think it's a marker of severity, yeah.
Mm-hmm. Did you try severity in there too then? Because you had severity, right?
Oh, for stage 2 and 3?
Yeah.
I haven't done that one yet. That's a good point. I need to do that.
I'm sure you've thought this all through, but as you went through this, I was thinking about temporality.
Right.
Right? Because you're looking at feeding as a risk factor for NEC, but what if it's actually preclinical NEC that causes failure to thrive that results in the need for feeding?
Absolutely. And so, it is messy. There's no two ways about that. That's why we did stop collecting the enteral feeding information. So it really depended again on the exposure. So for the enteral feeding, we stopped collecting enteral feeding once the NEC started. But and we did that for 5 days before, rather than just the 2 days. And we would collect the number of days on IV, like TPN as well. And but I think. So I can't rule that out. You're right. I mean, that's a really good point, and I need to put it in the limitations section.
Or is it an outcome?
Right. Yes. But I do think that the conventional thinking among the clinicians is that it's probably going to be more of this aggressive feeding that's the risk factor. But you're right. This is an excellent point to
probably
include.
Based on the fact that they used to just give these babies TPN. Not that I've been around and I'm not a NICU doctor, but these babies it's relatively new to start feeding them earlier and earlier. I mean, I feel like when I was in residency or med school, sort of feeding these very low birth weight and premature babies was really a new thing. Just giving them like these little drip feeds and breast milk versus formula and fortified or not. Like there was still, I don't know if it's totally figured out now anyway, but
You're right.
but
Yeah,
there is
absolutely.
data from before, and I think that's probably where the thought of like where does this come from? But I think there's probably a lot of confounders because certainly we have way more really young infants now than we did 20, 30 years ago. We save a lot more babies, so I agree it's confounding, but I wonder if that's really where like a lot of the clinicians, because I would say the lore that I sort of learned, but is that like the feeding is like the problem, or the potential issue, but I don't know if it's right, but I think it comes from.
I appreciate that. That's consistent with my understanding.
TPN before.
Please.
So if this is an uncommon event, how can we plan a prospective study in NICU to better capture those, cases and control? And what type of funding source have you thought about this? I know you mentioned about this as it come from a call you received early this year.
Oh, that was actually 2007.
2007, yeah.
Yeah,
2007,
so 10 years ago, yeah.
So you may have thought about those issues.
So first of all, in addition to NIH, which I've kind of been looking at eReporter and stuff like that, but there's a foundation, Thrasher Foundation, that funds this type of research. So, and fortunately, I actually did my master's with the director of Thrasher, so I'll reach out to him and I reached out to him earlier, and I think that he was also instrumental in saying, let's get some more preliminary data, but I think that this may be sufficient to get funding from Thrasher. And then as far as a prospective study, I don't plan on doing a prospective study. What I do want to do, first of all, I want to do multi-center study. This was at a single NICU. I think that if I can do something multi-center, then, I can really get larger power, but it'll probably be retrospective for the next stage. But then the other thing is if I can do, as I've shared some of these hypotheses with other clinicians, it really resonates with them as far as their concerns about some of the feeding products. And so if we can get enough people that when an outbreak is detected, that then, now that we're more thinking about it, that if an outbreak happens, we might be able to catch up more in time as an outbreak investigation rather than kind of just like what happened to me the first time, like everyone going to PubMed and saying, what's next, right? So we'll see. I mean, but yeah, I may not ever be able to do that prospective study.
So we're on the hour. We should probably end. Thank you very much.
Thank you very much. Thank you.